Hello, everyone. Welcome to Endoscopy Talks. I'm Dave Tweed from Colorado State University, and I'd like to thank you all for joining us on behalf of Colorado State University's new Translational Medicine Institute. Today, we're joined by Dr. Clarence Rawlings, who has been active in minimally invasive surgery for over 20 years. And in fact, he has described many of the laparoscopic assisted procedures. Following his retirement at the University of Georgia, where he taught for many, many years, he continues to practice by providing endoscopic training in veterinary hospitals throughout the U.S. And likely he would be happy to come to your hospital and provide training or laparoscopic tips. He's past president of the American College of Veterinary Surgeons. Dr. Rawlings co-edited Small Animal Endoscopy. He's passionate about helping veterinarians integrate endoscopy into their practices. I might point out, next to his excitement of minimally invasive surgery is also his excitement in fly fishing, and I'm sure he's going to tell us a little bit about that too. Dr. Rawlings is going to talk about urinary calculi and how to use the scope. And with that, Clarence, I'm going to turn it over to you.
Well, Dave, thank you. The urinary system has fascinated me since I started practicing, and it's really a neat one for a translational type of work in that it's a urinary system and the calculi is reasonably well understood, and in general there's a well accepted role of surgical removal for calculi. It's basically, we're talking about improving and modifying techniques as far as our accomplishments. Before I start out with the actual structured talk, I'd like to really thank the audience for showing up. It's kind of nice to be invited into your hospitals and your homes. And particularly like to thank CSU for having this program, for Dave Tweed putting it together. It's a lot of work. And to Carl Stort's Endoscopy, who supported so much of us in our training program, and Dr. Christopher Chamness. I have a special shout out to Jeff Dotson, who helped me get through and struggle and get the movies that you'll be seeing, or hopefully they'll be presented properly through PowerPoint on the Zoom. So we're going to talk about calculi. Calculi is quite obvious here on the bladders. Urinary, or the kidney ones, I'm not planning on doing those at all, but we will talk about urethra. I'd like to start out with a case of urinary calculi case to demonstrate the difference between traditional and scope or minimally invasive surgery. First case, it's a quick one. It's Claremont Animal Hospital, Dr. Mike Smith. I was scheduled and we were ready in the hospital to do a series of minimally invasive surgeries. Those were all laparoscopy. But this case was needed to go in the only OR first. I'll let you look at that. And when I walked by the monitor for the digital radiograph, I looked at it and I said, Mike, that's really a neat case. Either you or I can get those out, and when the animal's positioned in 10 or 15 minutes without an incision, we'll just go through from the rear urethra and pull them out. And Dr. Smith says, no, we can't do that. That's why not? And his response was, well, this is really a great new employee. She's in her first year here. She's comes to us from a very fine school. I'll tell you, it's University of Florida. And she did an internship in a practice, and she really wants to practice doing a traditional cystotomy. Now, if I happen to be, I have cameras around when I'm doing surgery a lot. If I happen to get a picture of you doing something really dumb or just inappropriate, I'll conceal your face and promise total secrecy. In this case, the surgeon made a call of midline laparotomy, just very appropriate to get to approach the bladder traditionally. This is it. And when she went in, she looked in there. She had her little spoon and forceps, but could not see any calculi. Then I suggested, and here I am, she's doing this as a solo surgeon, very routine type of approach. I asked her to go ahead and put her finger and feel around. She couldn't feel any stones. Thinking they might be in the urethra, I asked her to go ahead and pass the forceps from inside out and couldn't feel anything. So she was obviously frustrated, and having a guest in is always makes it uncomfortable for a younger surgeon. And so I went to Smith, may I scrub in? Because basically I'm looking at getting access to an OR table. So we did that. I repeated those same things. Had my fingers a little bit bigger, so we did go ahead, go down. We spent catheters from inside out, did not feel any resistance. It slid through very easily. So then I asked if I could go ahead and break out the scope a little bit early. So 1-point integrated cystoscope. And then this is one of my favorite instruments for taking out calculi, or smaller calculi. And this is a cartilage forceps that is used by arthroscopy. So these were the two items that we use. Now we've already thoroughly explored, and I don't know if any of you had this type of embarrassment happen to you, but as soon as we stuck the scope in, looked down the outflow tract, there they were. They were very irregularly shaped. You can imagine how a catheter would just bounce right around them. So here they are. Let me show you the movie. Now this is looking at them. We'll show you plenty of other things about how to take those out later on. So we were able to see our 5. This is the pre-op, and they came out very easily. And post-op, you see a little bit of water here that has been scattered around. So stopping at this particular point, I would begin to ask if it's able to use a cystoscope during calculi removal, a standard of practice. I'm not suggesting that every animal needs a cystoscope to remove calculi. What I am suggesting that the capability of using it, as in this case, is it's amazing how much more you can see when you've got good visibility. You don't have blood in the area, and much more. So our topics today, we're going to start off, we'll do bladder calculi, which will probably take up about half of the program. We'll stop at the end of that with some questions. Then after that, do urethral calculi. And then after another Q&A, go in some unusual cases. Before I do that, I do want to show you what looks like a normal cystoscopy, uroscopy. We'll then go ahead and talk about laparoscopic assisted cystoscopy and percutaneous lithotomy as far as removal of stones from the bladder. So this is a normal one, and you see going up the urethra. This, by the way, to me is one of the easiest techniques to teach a person in a laboratory or a hospital. It's very direct. You're having the animal in the back, so everything when you look up in here, you're looking ventrally. You can see the ureters coming in on both sides. By the way, you can see that they're very flattened out. This bladder is distended a little bit more than I'd like to if I was looking for ureters. Now, the best view by 4 is when you come out, because when you go in, to get a full view, you're actually scraping one side of the wall. Here, you can see the full view coming out. Then we'll also go ahead up from the vestibule up to the vagina, and up, or if you're in transcervical insemination, it's all the way at the end of the ridge. So that's what they look like normally. So dog's on its back and the urethra is ventral. And for me, since I'm reasonably comfortable in using a scope, this was just such a tremendous addition for doing urinary surgeries, and it's totally changed my approach. We're going to start off with something that we published a long time ago, and it was just a case after case study, case after case after case, as examples of laparoscopic cystoscopy. And later on, the Penn group called a percutaneous cystolithotomy, we're done a little bit differently. And hopefully you will see that we've all modified our approaches at times, primarily for calculi in the bladder and the urethra. And these urethra ones we're usually going to be going through the bladder to get them out of the urethra in the male dog. Female dogs will go directly from the outside in. Inflammatory polyps and examination are examples. I'd like to start off with our original approach. This was in Dr. Carlos Hodges' practice in Lehigh Valley, northern Pennsylvania. I was there. In fact, I spent a couple trips there and spent several days with him getting their program started, and an excellent surgeon. This particular dog was referred for endoscopic calculi removal. It had difficulty in urinating, occasional blood in the urine, and the referring veterinarian had referred it as urinary calculi. Carlos and I came out of the OR, and this was up on the screen because obviously you want to recheck things. And do you see the calculi? No, it's a little bit different than doing it in a meeting where I'm walking around the room and giving you out a pointer to point it out. But we both looked at each other and said, I don't see it. Do you want to call the referring veterinarian, or should I call him? Would it be better as an outsider to go ahead and call? Well, at any rate, we do take two views. This one was done next. The dog had been moved around considerably, and there is a second lateral radiograph. And so now you can see those are out nicely outlined, and including the one up here, where if you go back, you can see that. And this, one of the difficulties that the pelvis really does make it more difficult to diagnose. So anyways, we did have a single calculi, we thought. And now we're going to go ahead and do the laparoscopy assisted. This is one that uses two holes. One of them would be for the scope to go in, and then another one is to find where we think the front, the very cranial part of the bladder is. So we put that on. Female dogs, it's a little bit close here on the midline. Male dogs off to the side, and going ahead and putting in. I still use this technique if I have other things to do, and typically might be a liver biopsy. This is the way we originally did it. We had 4 traction sutures, which is bite and another one. So we basically have a cruciate to spread out the tension, pull it out snugly, keep it very snug, and then an incision just large enough to get the scope in and the calculi out. Now it's very critical, and there's some things I really want to stress here. It's very critical that you pull this up so that you can take a scope in, go down, looking through the outflow tract and having the monitor over here. In other words, like this monitor is back here. See how the monitor is right here. And for me, as a right-handed surgeon, I want to be on the patient's left side, so we're going down like this. When we're grasping truly, this should be horizontal. So basically, going on down. We'll talk about modifications to this later on. This I like. Dr. Hodges had not had any training as far as doing cystoscopy or endoscopy. He just has good hands, and he's a very experienced surgeon. I also like to use this because you're going to see grasping forceps and a calculi basket. Now this looks like it's about to fall apart. And indeed, these kind of stones can frequently. You have to be very careful. You squeeze them too hard. And here normally I'm going to be pulling everything out and then we'll go back in afterwards. You can see there's some fragments, and this is a calculi basket that we'll be pulling those out. It's amazing to me the number of these very small calculi we see with a scope that we don't see normally. If we have many small calculi now, we just preferably have a larger catheter from outside, where we can even do it from inside, or we'll actually roll the dog over, make sure that we can control where the effluent is coming and blast flush them on out. This is after surgery. These are the stone. This is a stone. Here, just an hour, very bright and alert. You can rationalize your need less analgesic, and that may be true, but at least I want to make sure they get analgesia. I've had several surgeries myself, and I certainly welcome the use of analgesia. Okay, this is going to be another one. This one was also done in the Northeast. This is IBG Metro West, just north of Boston. Dr. Nicole Amato was there. And when I go into practices, they frequently try to collect a bunch of calculi cases. That is example. This happened to be a struvite or inflammatory type of one that had failed medical treatment. I looked at the radiographs and I said, oh, I only do little ones. I don't want to do huge ones because we got to make a bigger incision to do a big one. But we got into discussion. We're here. We can use the scope. We're not going to be charging for it in that particular case as a training thing as far as the client is concerned. So we went ahead and did it. And I learned a lot at these situations. First off, one of the modifications I have, and this could be called, as Dr. Runge has, as far as percutaneous cystolithotomy, where we make one incision. We want that incision to be right about the cranial part, but I like to go ahead and use my cystoscope, put it in there, just a little SIM retractor or an Army Navy retractor, pull up just enough so I can really make sure that I don't have momentum over covering the part of the bladder I want to move it around, because sometimes you'll have intestines. So get the very cranial part, pull it on out. This is with the Babcock forceps, the less aggressive type, but pull it out. And then we're going to go ahead and use some traction sutures, make an incision just large enough to get the bladder out, or get the calculi out, Now, I routinely today go ahead, do basically a temporary cystopexy between the skin and the bladder wall all the way around, trying to control fluid loss. And so to limit the incision and urine contamination while improving total. So here we are. We've got this, and this, as you can see, is a thickened bladder wall. You can see that on the radiographs. These are the stones we took out. This is just with the Kelly forceps or Alice tissue forceps, something of that nature, because they're so large. And the small calculi in this case was removed by burst flushing via a larger urethral catheter. Here we've got it opened up, headed preferably towards the other side, not towards my shoes. And this is kind of a classic one here where a tremendous flush, the fluid's coming out. I'm sure there's all kinds of turbulence there if I was looking at it as a stream. And there is one of the little stones right at the very top being washed out. And flushing it, making sure, going back and looking with the scope to see what's there. We bladder, urethra examined with cystoscopy, going all the way to the outside. We've got cystotomy. We closed it with 4-out monocryl, and I would stress to do the rapidly absorbing. I'd like to patch with greater minimum because I only do a single layer. But when I do that, I save some of these tags. And then I pull the momentum over, pass the forceps through, grab one tag, tie it to another, so that I've got it tacked to the bladder without putting in additional sutures. Okay, so that shows us a couple things. One of them is we can do larger ones with a very minimal approach. It's obviously larger than the first one we described to you, but it is quite doable. And I will still use that traditional approach, but also do a lot of them when that's all is to be done, is just with a small mini laparotomy to get inside. Duke was a similar one, but we were getting into more complicated types of cases here. This one also had difficulty in urinating, straightening, hematuria, poorly responsible UTI, had been referred to the emergency animal hospital and referral center in basically Hotel Circle area of San Diego. Dr. Holly Mullen and Angela Sartor were there. And this one looks like 3 big ones. Same discussion. Well, we can do it. We're going to make an incision just long enough to get these things out. We're not going to do a full laparotomy with this. We're not going to be doing laparoscopy, although we could do a little bit, but same approach as before. You also can see not only that big one there, but we've got all these down here. And this has been going on for some time. Mini laparotomy, mini cystotomy removed the 3 large ones. Note that the bladder was sutured to the skin. We also, on these, we'll go ahead and make sure that we've cleaned just like we would do on any urinary tract surgery, out the prepuce, clean around the outside, and so that we can go ahead and feel halfway comfortable passing catheters back and forth. We flushed with urethra catheter and flushed and examined bladder with a 2.7. And we've also going to be using a urenoscope. Calculi was flushed with direct observation. 4-wire catheter was not required for most of the calculi. And as I show you the image, you actually see the calculi will skip along, going from outside into the bladder where we could remove them. This one also had tremendous proliferation here. In fact, I was very concerned that this was going to be a transitional cell carcinoma. Let me show you. Okay, what we're doing is we're inside the bladder, passing basically a chip on the end of the stick, if you will, a flexible scope. This is a calculi basket that is going through the operating channel, or sometimes we'll even move those beside it. But I want you to watch this as you're going to see it jump. Excuse me. All right, you'll see these calculi start. See, that was a jump that was kind of skipping on now, and that was with a flush from the end. So we're flushing from the tip of the urethra, the penis, and back and forth, then going on down. And I think we only had to remove a couple with the actual calculi basket. Post-operative, clean. Results, I did have an E. coli, stone analysis, I don't have that back. The biopsy was not a TCC, but a lymphocytic plasmacytic polypoid, very hemorrhagic cystitis. A lot of trauma was going on in that bladder, and particularly every time there would be a straining to void. The MIS advantages for Duke: small incision for the bladder and no incision in the urethra. Complete calculi removal from bladder and urethra, and urethra surgery obviously was involved. Alternatives for removal of the calculi from the bladder. One of them is to come through this opening that we've made, the abdominal wall, and actually use grasping instruments. And we'll show you a variety of those that are used. One thing I'll stress is to have this as horizontal as you can, and we'll show you why that's important later. You can also use the calculi basket, preferably going through the operating channel. Most of the time I'm using a 2.7, but on the smaller ones we will get down to 1.9. Or you can go ahead and have a catheter in from outside and vigorously flushing, whether in female in this one or as we had done with Duke. I'd like to go through some of the retrieval devices that I've used. Some of these are ones that I got involved because I was in a practice and didn't have every little toy I wanted at the university. That becomes a fact. This is just a basic retractor here, alligator forceps. The only problem is this is relatively small here. I use a lot of Babcock forceps, and that does have advantages that you can spin these, keeping the handle the way you're comfortable with it on the outside, but spin them so that when you grasp on you can actually see down through there. Nooses and so forth, boy, that is in desperation. I don't like that, but I do very much prefer using a 3 or preferably a 4-wire calculi basket. And this is one I'm going to show you a little bit more after the break here. This is actually, for me, was just a biopsy device that had ground down a little bit so it wouldn't bite. Here's one of my real preferred ones. This is nothing more than a cartilage forceps. that was being used for arthroscopy. Perfect for getting good grafts, but here again, you have to make them size appropriate. Looking at this, you can see how that would be very easy to grasp. Calculate this size. Now, before you do this, I think it really helps to practice with a little model. And it doesn't be real expensive. Dr. Chambliss will probably sell you one of these models for just $100 or so, or you can drink the rest of the Diet Coke, flush it out, and use that as the inside. And then all kinds of things, either real calculi from previous cases, or some little toys, or these are just beads. These are a little bit harder to handle because they're slick. And so I'd like to show you that. This is in a model that we use, the Pacific Medical developed for our use. And these are fake calculi, and you see going in and grabbing them. These, depending on their size, I'll pull straight out around the scope. Other times I take them down as just a combination between. Now, we ought to try to go in, always go ahead and grab the one that's the most obvious for you, the first one. Okay, now this is the way I would prefer for the position. You see how much easier it is when you see both sides of the forceps with the calculi in between. So that would be my preferred way. I'd like to take a break at this particular time and ask you about if you have questions about cystic or calculi removal. And Dr. Tweed asked me for the Q&As, he said, put in something that makes it a little bit more interesting, something that you enjoy doing. And I am thoroughly convinced that he was being kind of sneaky in that he's retiring now and he wants to see all the various things that he can do to keep himself occupied, whether it's riding bikes up and down mountains. Well, this is mine, and fishing is a passion of mine. I didn't say addiction, it's a passion. And these are some of my fishing companions last month on the upper end of the Lagnock River in Bristol Bay, Alaska. This big brown boar bear is harvesting right here. These are sockeye that are spawning. This is in the same area, a very nice rainbow that here's the guide and I were able to catch. And there's a major difference now. This is an underwater shot of that rainbow being released, whereas the big bear keeps and meats. Questions, Dr. Tweed?
Yeah, we got a couple of questions. One is, I don't have a cystoscope, but I have a 5mm laparoscope. Can I use that? Well,
this is something that you did at Colorado State there. Dr. Baudet started using it, and you can see with it, yes. However, I have and I love them. And I used to use two scopes, laparoscope to get in and then into the bladder. But I really like having an operating channel and be able to control the fluids going in with the cystoscope. So it's one opportunity to expand your scope selection. It can be done. I find it easier with the cystoscope.
Okay. This one says, should I always take a radiograph after I remove the stones, or can I be pretty assured that I've got them all out when I use the scope?
Yeah, I'm assuming this is not after traditional technique, but with a scope technique.
Right. I think so.
And I strongly encourage at least a lateral view. I remember in the first 10 or so that we were doing, where we saw the calculi coming up out of the outflow tract, we missed it, then we saw it again, we grabbed it and pulled it out. I went to look at the radiograph and saw that there was a stone there at the same time that the resident went back and re-looked at the image to realize there were two of them. But I think it's very important. It is very critical that you do line things up so that when you go from the bladder, pulled up the abdominal wall, so that you have a straight shot. If you're not careful, if you have some of the bladder going cranial, it is very easy to lose stones there. So I would go ahead and take at least one while the animal is asleep.
Okay. And then I have one other good question. What are your criteria of when a scope should not be used for removing calculi from the bladder?
Okay, well, when I started out, it was, as you can see, the transition there, big stones or lots of stones were ones that we would try to avoid. Now, with experience, and I think a lot of other people probably have done the same thing, you realize that you can do larger ones. So that's not. Obviously, I don't want to go ahead and do a mini laparotomy if I can take them out through the urethra. So we've really expanded things quite a lot, I think. I will be showing you a case a little bit later on where the dog definitely required other urinary surgery at the same time. But we've really expanded what we can take out, I think.
Okay, that's all the questions we have for now.
Okay, nobody has questions on how much it costs to do this, huh?
Not yet.
Okay. Tipper was at the University of Georgia. It was one that I was involved in when I was there full time. This is a before and after of his stones. This is one that had stones in the urethra. I got it cut off right there now. But here we're using, this happened to be a fiber optic. That was before we had the little chip or the camera out here on the end. And then looks like a 1.9 cystoscope. Thing that was interesting on this, we took these stones out and then passed the scope and found another one that was in a very ugly lesion right behind, more of a Rossi type lesion, right behind the os penis. And when we took that one out, it was not colored with all this nice yellow urochromes, but rather it had obviously been sitting out there for some time. Now the dog could void around it. It just was one of those that, you know, moved from a 3-point or 4-point stance, a 3-point stance to a 4-point stance. He had to strain, but he could void. It's just so irregular shaped versus a lot of the inflammatory or infectious type of calculi, the big round balls that obstruct. So I wanted to pass it because one of the things I really learned, now this I'm going to be showing you is in the outflow tract and the very proximal urethra of a male dog, passing a catheter from outside in. And I thought I had very sensitive hands until I watched that catheter going around this misshapen, ugly looking calculus, and I couldn't feel it. So that I would caution you. I know that when it started out, man, we take catheters from inside out and you would be very confident that you had everything out. But this is one that we could go around. Okay, I'd like to start off now. We're going to talk about removal of stones via the urethra in female dogs. We repeat, removal of stones in female dogs, urethra into the bladder and pulling it out with a cystoscope. This particular client was pretty special. This is when I was working at the Veterinary Referral Associates in Gaithersburg, VCA practice. Dr. Dave Taylor was just a great sponsor, and this client came in to see me. Her dog had had 2 prior cystotomies. It was needing another one. Repeated straining to urinate, classical signs, and the client was very knowledgeable. This is a surgery nurse who worked in operating room where they were using lots of scopes, and she was very unhappy. And I don't know if you experienced, but this lady, for instance, after prior cystotomies, this dog was most uncomfortable, did not want to jump up on the couch with her and her daughter. It was a major problem. She also had a problem as far as doing any spatial diet feeding because her child was, I don't know, 4 or 5 years old, and this girl would only, the dog would only eat when this girl would offer it by hand. Kind of strange. I don't know if you have clients that come in and tell you how to do your job, but at any rate, I was comfortable. This is the calculi. And I always felt like an orthopedic surgery starting to measure implants, but at any rate, I felt like this was within the size range of a 2.7, which you should be able should be able to go in and retrieve. And so we did that. The movie doesn't work on, but I'm going to show you a movie anyways. So this is the stone coming out of the bladder into the outflow tract, being pulled to the outside with a basket catheter. And here it is. Really a very neat procedure. No incisions in it. You're sending the dog home a lot of times as soon as they wake up. So very nice. These types of patients that are continuous stone formers certainly are ones that I would recommend regular, not just radiographs, but ultrasound as well to monitor to see if they form. And these do, you can go back and retrieve them again at a later date, or the new stones. This one was the one that had the movie, Sadie. Sadie is one that I did in the pet hospital at Besserman City, North Carolina, with Dr. John LaStella. And I think we had 3 urinary cases that day. I think you can probably see that one down there. Again, another one that with this dachshund, one that we should be able to go from outside, use the scope, grab it with a Calculi basket and going out. This is briefly what we're doing. We send this through the operating channel, get it inside, open it up, get it engaged, then tighten up a little bit. And I want to stress that if you're not careful, you can really fracture these stones easily. So here we are. I want to tighten up, but not too much. I'm almost cradling it sometimes, like you would be if you were carrying an uncooked egg or unboiled egg around in a spoon. I want to gently hold it so that I don't end up going ahead and lose it. And these are kind of fun. They do require a bit of patience. You also have to work on the distension of the bladder. If you blow a bladder up too much, then it looks like a balloon that you come in. You really can't get around. There's a corner in there where the ureters enter that is hard to see. You also have to have it clear, but if you have too much flow going, you'll just all of a sudden you'll think you're in a snowstorm and with little flurries and everything's flying over the place. So let me show you again. And being gentle, baby moves, rotating the instrument as well as moving back and forth, sometimes even having a little bit of manipulation from the outside. Just these excellent procedures. These are, again, really enjoyed by the client and the pet. It is a major thing to be able to do that. Now, this is a Theodore Animal Hospital, Dr. Carl Myers, and he's another general practitioner that really has become very talented, very skilled with using a scope. I was there, we came out, and this shows up on a pre-op for a TTA, and you can see the stones. Now, I'm not showing you this just because this is the second case I've done. I'm showing you this because I had a real boo-boo on this one, and I'm trying to let you learn by my mistakes and not have these problems. So this is honey cystoscopy using an integrated cystoscope with a Calculi basket. Now I'm going to try to stop this at certain points, but we've got several stones we're taking out. You can see them. You'd like to get one, maybe no more than 2 lined up. Okay, what I've done is stop this where you can see that I've got 1 stone within the basket properly. Or at least you can see there is a stone in the basket. Hopefully it's properly. But I also got 2 that's outside in the outflow tract that are being pulled along in front. So I'm going to take this through a couple times here, let you look at it. This is not what to do. I should have taken those right there, gotten the outside one first. But these would move in and out. because when I got all the way to the end of the urethra, right in the meatus, going into the vestibule, it obstructed. Now, fortunately, I was able to open it up using number 11 blade and just do a little tiny metotomy, and it came on out, and the others followed, so that I got three instead of one. But that is something to be very careful about. So distension is a major thing, getting appropriate distension, getting it flushed out enough that you can see you're clear. So these are the 6 stones that came out, and you can get a very good viewing of it to make sure you're out, but I still would go ahead. So right now, questions or comments on urethral catheters, and before you do it, I'll show you another fishing one. Now this, and Tweet, you've got to come out and spend some time with me. This is one of my ponds. It's one that I was involved in building. This is a Google satellite map of it. You can see right here, these are submerged ridges, lots of structure in it. You can see where the pre-impoundment creek channel ran. I've even got little islands here and so forth, nice ramp and so forth. And in fact, this is one that University of Georgia Fish Biology Group comes out and uses as a teaching laboratory for students and continuing education programs. And I was rewarded with all that management work. This is from April. This is a 9-pound, 12-ounce bass that had apparently already spawned, because I'm sure this is a double-digit one. Now, time for questions.
Yeah, we've got a couple of questions. One going back to your laparoscopic assisted, and that is, besides the cystopexy, how can you prevent the leakage of infected urine into the abdomen in patients with UTIs?
Excellent question, without question. And then, we tell you to try to control the UTI pre-op, but that's not always easily done clinically. I do look back in there. When I was doing them all as a laparoscopic assisted, I actually would do that. I found one that had some fluid in. I definitely go ahead and have a suction tip there and using it, and try to make sure I've got a good pexy all the way around. But that is a concern. It's not something that is then generally reported or that we've seen in cases. That's something to be very attentive to.
Okay. I've got another question is, what's the maximum number of stones you will attempt to take out transurethral?
Transurethra?
Yeah.
I don't really have a number, but it kind of depends on the day, I guess. But I would hate to start doing more than half a dozen or a dozen. And that's with one's appropriate size too. Size is the biggest consideration.
Okay. And then you didn't speak about using laser lithotripsy. Is that something that people should think about?
Well, there's been a lot of people that have bought lasers. They're not particularly cheap, but so it's frequently been in institutions. And I think there's been some excellent work done on that. I've watched it being done. I'm not sure that I want to get involved in doing it myself. There are some criteria there that are even more restrictive, I think, from the standpoint of size and number, because you don't want to do, I'm not a surgeon that likes to do routinely 4- and 6-hour procedures.
Yeah. Okay, those are the questions we have so far.
All right, I'm going to go now from those to some oddball stuff or things that I think are very educational. This one was a case that done at UGA, managed by our senior resident at that time, Dr. Kevin Stifler. Did an excellent job. Actually, I think Karen Cornell was in charge on the first management, and then I came on the next day type of thing. Dog's golden retriever, everybody's most favorite loving dog, had quite a bit of work done already. But this particular problem, it came to us 3 days after it started with the veterinarian. By the way, you're going to really question what the results were done, but this is an excellent referring veterinarian, and more importantly, not only very confident, but also realized that this is time to refer this case and get it out of his town. Urethral obstruction had been treated by the RDVM. The dog had since developed dysuria, vomiting, had a cystic catheter, removed basically 250 mils of urine, developed swelling around the penis and scrotum. It looked ugly. So here we are. We still have stones in here. You see the TVO. And actually the dog's chemistry and profile were within normal range, but you can see how it's been very uncomfortable if he's got all that urine in there, and that was probably how things sort of started. Urine analysis is missing in action. One of the real frustrations, very easy to criticize when you come in the day and you're managing it, but that's certainly something we would like to have. These are, the next morning, these are the retrograde urethograms, and actually, as you can imagine, this is a fistulogram here. The urethra is actually here. I hope you can see that. And then after it's a little bit of collapsing, voiding, running out, now being distended, you can see the urethra right there. So this happens to be a fiber optic scope being used here, and you can see one of the problems with fiber optics. But caudal laparotomy, ventral cystotomy was done that night. Calculi were removed. They used the urethroscope to go from outside in because there's a problem in passing a catheter. When the dog was finished surgery, it had a urethra catheter in, a 10 French urethra, and then a cystostomy catheter to make sure it was being drained 18. They did a real fine job of management. All these little dots are fibers. So sure, the dots didn't increase in number that evening, but there's a dozen there. Now, here you're going to see, it looks like a double barrel shotgun here. This is the opening going through the urethra, going on towards the bladder. This is the much larger opening of the fistula. And here they're going to turn it around, move it back and forth enough, maybe even a little bit of external massage. That's going into fistula. And now, hopefully we can get up the urethra this time. Okay, and now you're see going the rest of the way. The owner was recommended to have a scrotal urethrostomy done the next day after the basically emergency surgery, and they refused. I've done a lot of these. In fact, this is from 1976, from a little brief book chapter that I had in an atlas of surgery back from, gosh, the 70s, a long time ago. But I guess the frustrations I had in the scrotal urethrostomy, so many of those dogs ended up being in the hospital for over a week, just monitoring the patient, making sure the dog did not abuse that area too much. It's a major surgery as far as, even though it's kind of fun and easy to do, anatomically, it's not one that I really like doing for the patient. This dog did culture positive for staph. It's not treated antibiotics. It's from a new age, and wait until we can solve the problem. It had good drainage of everything, closed suction system, side brace, bruising and swelling resolved very quickly. At 9 days, there were a lot of rods there, and E. coli, and was put on the antibiotics eventually. This is the dog at 3 months, and basically what we're doing is changing it. Is not going in and suturing and repairing that urethra. But what we were doing is leaving a good conduit for urine to get out and letting it heal slowly. And this is something almost more of a human approach rather than a rolling in there and trying to go ahead and to suture it up, is to let it heal by itself around the catheter. Did very well. Okay, Benny. This one is also referred from an excellent veterinary practice. This happened to be southeast, the other was north of Athens. This cat had a perineal urethropy done on it 11 months previously, went great for 10 months. Then it started having some obstruction, and then it had repeated catheterization at least once per week. Was given phenoxybenzamine and Valium. This is the contrast study. This one actually stayed on medicine. I just came in, was the cystoscopist. And you can see there appeared to be repetitive. There's something was wrong about this level of the urethra. This is just inside, maybe about well within the reach of a stiff PU, or I'm sorry, urethral calculi. Okay, this one we could pass a 3.5 French catheter in, but this is cystoscopy. And what I want you to show you is this. Anyone's done very much scope work with small scopes is aware that this is something very important to avoid. Now, what I was doing here was I had tried to go up with the previous 1.9 cystoscope, not the integrated one, but where I had actually taken the scope out and used it as some people call naked or naked. And what I've done is I've bent the scope just very slightly. Not a good thing. A little bit more, or maybe just a little jiggle, and that would have broken. So here we're going to let it come out. And I was able to only get past this stricture if I actually had when I filled up the bladder with fluid from the 3.5 scope, and then have a student to go ahead and squeeze on the bladder to have it voiding, so that I actually could go ahead and eventually get in, and we'll eventually approach the bladder. This is one that I would love to try to manage. I can imagine all kinds of ways of managing, but the owner did not go ahead with any management at all. And so I was frustrated I wasn't the primary talker. Don't do that. Okay, another one. This was when I was practicing at Veterinary Referral Association. Recurrent UTI, cystic calculi in this 8-year-old female spayed West Highland Terrier. Continued scooting. And here is the okay, lab work, no growth. Let me go back here, make sure. Okay, yeah, right here, 7 weeks previously was calculi removal by the RDVM. Interesting enough, though, this one did not have any growth on it, but on ultrasound, they saw what they thought was suture. So what I'm going to do is show you cystoscopy. Now this cat is on its, or I'm sorry, this dog is on its back. And so we're looking up at the ventrum of the bladder where the ventral cystotomy had been formed. I assure you that the movie's you're going to see it here in just a little bit. Okay. Right there is the, right here are the sutures. So what I'm going to do now is show you how to untie those. So we've got our a grasper that's going through the operating channel of the cystoscope. And just baby moves, be careful. Slip it forward a little bit, grab it. And well, I not quite untie, but go ahead, pull it on out. Big tip. We see calculi, suture. This suture is in there for 2 months. I've seen suture that have been in there several months. Suture that, non-absorbable suture that's been in there a few years, particularly those that have calculi on. I'd like to conclude with my clinical impressions and then look at the literature just a little bit in this area. I find cystoscopy is relatively easy to learn how to do. On a couple of studies that I'll show to you, there was no significant difference in time, but I can assure you that the first few that I did as I was fumbling along, I could have gotten the stones out in half the time doing traditional. Now, in many cases, it's probably actually a little bit quicker. It does require some creativity and persistence, that's some patience to do that. It's just amazing how much better lighting and visualization. You see many, many small stones that you never realize is there. And I think Dr. Monet has stressed in the past that you're just waiting for little stones to grow up. You're not seeing new stones form necessarily, although I think both obviously happens. You can get an excellent evaluation, but I do recommend lateral. You can definitely combine it with other procedures. The most common one would be a cryptorchid castration or a liver biopsy, particularly liver biopsy. You can use it for biopsies as well. Limited, almost no urine contamination. And I think very definitely decreased trauma and hemorrhage. And I always try to encourage people that are going in to get a biopsy of the mucosa to go ahead and get that first thing, because after you puddle around a little bit, it really gets very inflamed. It's a very vascular area. Clients in general love it, and frankly, that's what I would want for myself, is to have cystoscopy done, whether it's from outside in or lap-assisted type. A couple of the people doing the case studies commented it was more expensive, and I say hooray. This is expensive equipment. It's expensive for you to learn how to use it, and you're also going to have to practice a little bit in your hospital. So it should cost more. These are some of the relevant studies. I put just enough of the name so you kind of get an idea of what it's about. This is our first one, in 2003 publication. Obviously, I was doing it a little bit before then, although it is just case after case after case. 20 years later, I do that, but there's lots of modifications I include. And if I'm doing lab assisted, that's basically when I'm also going ahead and doing a liver biopsy or something else. There are several of these. I don't particularly like doing in that particular way, but I picked up some stuff that was very useful. And so I encourage you. The nice thing is that you don't have to write them down right now, because you can get them when you go back and relook at it if you want to. Is there evidence that MIS is better than traditional calculi NDs? More complete calculi by scope versus traditional? It's borderline as far as what's in there. Frequently, they're limited on number of cases, even though trying to put together 75 cases or so is a challenge. Decreased complication rates with the scope. There's some indication of that, but not in all of them. Earlier discharge for the scope. That discharge varies so tremendously depending on the practice I'm in. I see a lot of these that are sent home as soon as they start voiding, so that they're out of the hospital in 3 or 4 hours. Not an uncommon situation, but certainly keeping them in for a couple of days. Reduce hemorrhage in scope, like definitely it happens. These are some of the reported complications for traditional techniques. Recurrent calculi formation, need for serial surgeries, stone formation on suture, but that's basically when you're using non-absorbable. Strictures, adhesions, bleeding, neuroabdomen pain, other life-threatening. So my question is calculi removal without the capability of using a cystoscope below standard of practice? I'm not saying they all need it, but I think there's good evidence and experience that's saying it's improved visibility. I think you get better, more complete stone removal, decreased trauma, decreased urine contamination. I'd like to open it up for questions. I think I'm right at my 1 hour limit here. I do have on the fishing. Boy, Dave, it's hard for me to pick the right ones that I wanted to use for that, but this one was my first trip. It was 2 years ago to Mongolia to fish for taimen. This is with the research group, the World Quality Water group at University of Nevada, Reno. And now these things, they are scarce and they are violent, premier predators. They are top line. In fact, they've been caught up to over 100 pounds. Catching one a day marks you as a very lucky or fortunate fisherman. This happens to be a double, two caught at the same time. We have these both fighting on the same time, going aerial. This is the Dean of Science at UNR, Jeff Thompson, and then myself. Okay, any questions? I'm sure that there's probably some.
Yeah, there are a couple of questions. I think one question you inspired, but I think you answered, and that was, do you charge more, the same, or less doing traditional surgery versus laparoscopic assisted?
Traditional surgery is probably going to be the benchmark, and you go up because you unquestionably have got, you got to go ahead and figure in the cost of that equipment over time, but you also have fixed cost of learning how to do it and so forth. So yes, even if it takes less time, I think you need to charge appropriate.
There's also a question. Okay. There was also a question, and I'm not sure what this related to, but how many days using Clavamox would you do with this pathology? So I assume they're talking about one that had a urinary tract infection. And then a second question, which probably also would go along with this, is if you're doing transurethral cystoscopy and it being difficult to be completely sterile, do you put patients on prophylactic antibiotics?
Only perioperatively normally, and then like that one case, and we did have at that time, University of Georgia had some people really involved in urinary tract infections. So I go to the experts for those questions.
Okay. Well,
I think is the way to go, but even that you're going to see differences.
Okay, well, Clarence, I need to thank you for a fantastic presentation. It was really great. And I'd like to thank everybody in the audience for joining in with us. Next week, we're going to hear from Dr. Lorenzo Crosta from Australia, and his talk is entitled God Created Birds for Endoscopy, an Introduction. This will be our first of many, hopefully, exotic species presentations. So Dr. Crosta will be next Wednesday, September 30th at 8 p.m. That's New York time. And also a reminder that you can watch this presentation or any of the previous presentations free online at endoscopytalks.com. So wishing you all well in your practice, and of course the best health during this challenging time, and we look forward to seeing you again next week. So thank you very much, everyone.